Thank you for all making time to come today. It's 6 o'clock on a Wednesday. There's many other things you could be doing. But what I'd like to do in the next hour is take on a bit of a journey of what we're learning about young people with heart disease, with a particular focus on sudden death. Before I do that, I just want to acknowledge that I'm the most privileged and lucky person in the world because I work in 3 leading internationally recognised institutions. The University of Sydney that you're on the grounds of, and I've almost completed my 3rd degree at the University of Sydney, nearly finished my Masters in Public Health. Centenary Institute, which is a world-class institute which looks at all aspects of molecular medicine, cancer, immunology, infectious diseases, and of course cardiovascular disease. And the wonderful Royal Prince Alfred Hospital, the oldest teaching hospital where I did all my training. So I come to work every day really excited and happy that I can be part of these magnificent institutions. So we'll get on with talking about genetics of heart disease in young people and ultimately get on to sudden death. But when you think of heart disease, you usually have this sort of image in your head. An overweight, usually a male, high cholesterol, high blood pressure, a smoker, watches the footy all day, and has blocked up arteries everywhere. You don't often think of young people with heart disease, particularly apparently fit, healthy athletes, sports stars, etc. You almost can't believe it when you hear in the news that a young person has died suddenly. A young person at the city of Surf has crawled over the finish line and died suddenly. A schoolboy, a local schoolboy, dying in the grounds of the school. So the awareness of heart disease in children or young adults in itself is a major knowledge and base that we really had no idea of 10 years ago. But now understanding what these diseases are, how they cause sudden death, etc., are really key aspects. So this is all new research. In the last 20 years, we've identified at least 45 different cardiovascular conditions which are directly caused by an underlying gene problem. So each of us in this room have about 22,000 genes, and a fault in one of those genes can lead to a whole array of cardiovascular conditions. These are not gene changes that change your risk or make you more likely to develop diabetes or something like that. These are gene changes which directly cause these conditions. And as you can see, whether it's the heart muscle, whether it's the electrical system of the heart, whether it's blood vessels, whether it's metabolic problems like high cholesterol, whether it's congenital problems like holes in the heart, all of these different cardiovascular conditions can be caused by faults in genes that we're born with. A complication of all of these conditions is sudden death in the young. And I think everyone in this room has either heard of young people dying suddenly, knows of families who have lost people at an early age in life, have heard of sporting stars on football fields or basketball courts dying suddenly. The key factor here is that these are otherwise healthy people. These people you see on the screen have been playing for years, maybe for decades. They're often elite athletes, but on a particular day, for whatever reason, they culminate in an arrhythmia of the heart, a cardiac arrest, and are unable to be resuscitated and die suddenly. On the world stage, it makes a lot of news, but also in our local communities. We're always hearing of young people at schools, swimmers, this young lady is a very talented 15-year-old swimmer who died suddenly, up-and-coming soccer stars, etc. While sudden death in the young is a relatively rare event, the implications of the condition are massive. They're massive for the family involved, of course. It's a tragedy like no other. But it affects the whole community. It disrupts the whole community's interactions, and the sadness spans many populations and many thousands of people. And so understanding why young people die suddenly, but of course the ultimate goal of trying to prevent young people dying suddenly is sort of at the core of what we're doing in our laboratory and in our research team. So very simply, why do young people die suddenly? Now I have to make a definition issue here. Young, I'm talking about under the age of 35. I was really happy with that definition when I was under 35, because I could call myself young. Then I reached 40 years, so I changed the international definition. I made it under 40. But now I'm 47, so I've gone back to 35 years of age as being young, because I can't justify it anymore. So young is under the age of 35 years, and the reason we choose that is because over the age of 35, the most common cause of sudden death in the community is coronary artery disease, blocked arteries, which are due to the things I mentioned before, blood pressure, smoking, cholesterol, etc. But in young people, what are the causes? Generally speaking, there are two categories. The first category is disorders which affect the muscle or the structure of the heart. And I'm going to give you one example of that, of one of the cardiomyopathies. So these are heart muscle conditions, but many other conditions you can see listed there. The second group of conditions are ones which don't so much affect the structure of the heart, but the electrical system of the heart. Remember that the heart, in its simplest terms, the heart is a pump, and the pump needs electricity. And so you can have problems with the pump of the heart, which are the structural causes, or electrical problems of the heart. And you might have heard of conditions like LQTS syndrome and others. So for the next few minutes, I just want to give you two examples, one of each, to highlight some of the aspects of what these diseases are. What are these genetic heart diseases that cause young people to die suddenly? So I'll start with hypertrophic cardiomyopathy as an example of the structural problem of the heart. So this is Reggie Lewis. Many of you know this very famous basketballer from the Boston Celtics. Died while training for the NBL finals many years ago in his 20s, and was found to have this condition called hypertrophic cardiomyopathy. What does that mean? Well, this is the first description of the condition, and I show you this because medical history is absolutely fascinating, especially when we look at it looking back. Nowadays, we can use the most advanced techniques to work out diagnosis of disease, MRIs, PET scans, all sorts of things we can do. In 1957, when this gentleman, Donald Tier, who was a pathologist at St George's Hospital, he identified 8 cases of this condition of hypertrophic cardiomyopathy where there was thickening of the heart muscle. But he didn't have fancy microscopes, he didn't have an MRI machine, he didn't have a CAT scan, he just had his eyes. And he actually called this condition a tumour of the heart because it looked like a big ball of muscle, and he thought it was a tumour. That's a very reasonable observation. Keep that in mind. He thought it was a tumour of the heart. You can see the heart there very thickened on the right-hand side, all in black and white. And the power of observation was amazing because even as he finished writing the article, he added a little addendum to the article. It was like a diary entry. And he said, while I was doing this, writing this paper, one of the relatives of one of the people who I'd just done a post-mortem on also had a collapse and had the same sort of symptoms. So already in the 1950s, he was thinking about the genetic or inherited aspects of the condition. So always fascinating to see that. So what is hypertrophic cardiomyopathy? This slide summarises the key features. It's an abnormal thickening of the heart muscle. So you'll have to take my word for it. This is a grossly thickened heart. There's hardly any chamber of the heart. This is the main pumping chamber of the heart, the left ventricle. There's white areas, which I hope you can appreciate, just areas of scar tissue. And scar tissue is very bad in the heart because it's what we call a substrate for rhythm problems, which can lead to cardiac arrests. Here is an echocardiogram of a living 17-year-old boy. No symptoms. This is the left ventricle of the heart. And the key point I want to show you is this is the normal thickness of the heart. This is the 3 times or more thickening of the heart. So it's an amazing thickening of the muscle of the heart, which can lead to things like heart failure, rhythm problems, and in the worst situation, sudden death. When you look at athletes, sudden death in athletes, we call it HCM or hypertrophic cardiomyopathy. About 1/3 of US athletes, when they're found dead after sporting events or during or after sport, the cause of death is hypertrophic cardiomyopathy in 1/3. So it's the commonest structural cause of sudden death in young people, including athletes. One of the things I want to convey to you today is the amazing advances in genetic technologies. So remember I said in the 1950s we called this condition a tumour of the heart. We now know the condition as a complex genetic condition which affects what we call the sarcomere of the heart. The sarcomere of the heart, it can also be called the motor unit. I told you the heart is a pump, and the pump is made up of a whole bunch of little motor units which all work together to make the heart pump. This condition is not a tumour of the heart, it's a genetic condition which affects the very core of the heart, which is the sarcomere, or the motor units. And I won't go through the list, but our group and other groups around the world have identified many of these genes which cause hypertrophic cardiomyopathy. How is this helpful for the patient? How is this helpful in families? Well, it's helpful because we can not only diagnose disease using ECGs and echocardiograms, in relatives of people with this condition, we can use the gene test to determine whether they do or don't have a risk of developing the condition. It's called predictive testing. This is to remind you that, firstly, I hope you will understand this photo. So here is the child, here's the father who's got horizontal stripes, the mother's got vertical, and the child gets half of each, because the child's like checked. So that's genetic, that's as simple as I get in terms of genetic inheritance. Half from mum, half from dad. All of these genetic heart conditions are inherited in what's called an autosomal dominant fashion. That means there's a 1 in 2 chance of the offspring of any one of these conditions of having the same condition. So if you have one patient in front of you with hypertrophic cardiomyopathy or a genetic heart condition, it's very likely that one of the parents has it. It's likely that one of the siblings have it, 1 out of 2. And if they have children, 1 out of 2 of the children will have the condition. So for one patient, you end up with 4 or 5 patients. And so what we can do in families, and this is work that we do in our laboratory and in our clinics at Royal Consultant Hospital, the genetic counsellors see these patients. We find the gene problem in the first person in the family. A square is a male, a circle is a female. If it's filled in, they have disease. And then we map in the family who else has the gene or doesn't have the gene. So for example, this child, this son, does not have the gene problem. We can say goodbye to that child and say you don't have to come back ever again because you don't have the gene, you're not going to get the condition. So this is how genetics has really changed our world in terms of allowing us to work out who's at risk in families. And I'm just showing you this in hypertrophic cardiomyopathy, but it's the same principle in all the other conditions. Recently there's been some really famous people, now you may laugh, but it's believed that Elvis actually had a genetic fault that causes hypertrophic cardiomyopathy. Now Elvis had many other reasons why he died at an early age. No doubt about it, overweight, smoker, all sorts of other things. But there's a guy in America who collects hair from people, famous people, and he took the hair and actually extracted the DNA of Elvis because he'd cut Elvis's hair in the past and did a genetic analysis and found a gene fault in one of the key genes in hypertrophic cardiomyopathy. So whether he really had it or didn't have it, whether it was really his hair or it wasn't his hair, it was in all the news stories a few months ago. So maybe even Elvis left the room with a genetic mutation. So that's an example of a structural cause of heart disease, which is genetic. I'm now going to tell you about one example of an electrical problem of the heart. And this is a syndrome called Familial long QT syndrome. Does anyone know who this person is, apart from people in my group? Who's that? Is that Nick? No. Yes, go for it. No, it's not. It's a good. She looks like her, but it's not. You're the first person that's ever had a go at actually finding out who this person is. I'll come back to her. Familial long QT syndrome is a very similar condition in the sense it's a genetically inherited condition. There's a 1 in 2 chance that offspring will have the same condition. But the main problem with the condition is not a structural problem, it's an electrical problem. So there's a short-circuiting of the electrical system which can lead to very fast heart rhythms, which then ultimately can lead to cardiac arrest and death. You can see on this very simple, colourful diagram, what we call the QT interval is a region on the ECG that we do on patients, and if that's prolonged, it makes the heart more likely to go into these abnormal rhythms. So we can measure that on the ECG. Blackouts and sudden death are not common, but the worst complications of familial long QT syndrome, and many genes are involved. There's an ECG down here that shows long QT syndrome. So for the students in the audience, you can see this very prolonged QT interval. And the problem with this rhythm is that it can lead to this rhythm, which is a rhythm called torsade de pointe. We have funny things in medicine, but torsade de pointe is the changing of the points in French. Believe it or not, that was a French accent. Changing of points. And the only outcome of this is a cardiac arrest. and the only thing you can do to treat it is to apply electrical pulse or electrical cardioversion and revert the rhythm. So that's long QT syndrome, and the exciting thing about long QT syndrome is that not only has the genetics helped us in diagnosis, which is very, very important, it's also guiding us a little bit in therapy. So bear with me for a moment. There's at least 13 different genes which cause long QT syndrome. The top 3 we just called very originally long QT 1, 2, and 3. But what we know is that each of those subtypes of long QT syndrome have different clinical features. So in long QT1, they respond better, for example, to beta blockers than, let's say, long QT3. So their response to therapy is different. So the genotype is guiding us in terms of what to treat the patients with. We also look at triggers of sudden death. In what circumstances do these people die suddenly? In long QT1, it's commonly in swimming. Long QT2, it's often loud noises or what we call auditory triggers. Alarm clocks suddenly going off can trigger a sudden death event. And long QT3 tends to occur at night time during sleep. So we're learning more about the genetics, not only to help us in diagnosis, but also in guiding therapy and prognosis. And so this is a really exciting thing. Now, when I started out in research 15 years ago, the thing I wanted to do more than anything else was to make sure we did research that actually changes patients' lives. I'm not the person that sits in a corner of a room for 20 years and works on a molecule that's really interesting and get lots of important information but has no clinical relevance. I'm pleased to say that many of the things I'm talking about today have already translated into the improved care of patients, and this is an example. So coming back to this person, so this is Dana Vollmer. So she's an American swimmer, an elite swimmer. She was diagnosed with long QT syndrome many years ago as a child or an early teenager. They told her she can't do high-level exercise, and what did I tell her about long QT1? You can't swim. So she was determined to actually become the best in the world in her swimming events, of which her favourite one was the 100 metres butterfly. She decided the risk of dying suddenly was significant, but her passion to actually become the world's best was more important. So she took the risk. She bought a defibrillator, she took it to the pool every morning when she went training. She'd put it by the side of the pool and go for a swim. She'd often go 4 or 5 in the morning, so there'd actually be nobody at the pool that could use the device. But she did it. And she did it, and she did it for years and years. And she got to the 2012 Olympics, and she won the gold medal. So here's in the 100 metre butterfly, which was a key event. So what this is telling you a couple of things, but the first thing is that the patient's determination is very strong, and the importance of involving the patient in every decision-making process. For the medical students in the audience, in any aspect of medicine, you must be able to integrate your recommendations and your thoughts and your advice with what the patient desires. Because in the end, if the patient is unhappy with what you're advising, it's going to be hard to implement it. So the patient has a role. The doctors were obviously very worried about her, but she was made an informed decision, kept playing, and she kept swimming, and succeeded well. So that's Dana Vollmer. So what I've told you so far is about the causes of sudden death in the young. I'll give you 2 examples. One is structural heart condition, hypertrophic cardiomyopathy. One an electrical condition called long QT syndrome. So now I want to focus a bit more on how today we are caring for families where there has been a sudden death. And I'll just remind you that Royal Prince Alfred Hospital is the home of 2 very important clinics. The Hypertrophic Cardiomyopathy Clinic was established in 1991 and is recognised internationally as the first hypertrophic cardiomyopathy centre. The second was the Genetic Heart Disease Clinic, which when I came back from overseas training, Dr. Joan Ingalls and myself established that clinic around 2003-2004 and is now being modelled in Brisbane and Melbourne as a specialty centre for people with genetic heart diseases. Unfortunately or fortunately, the Genetic Heart Disease Clinic has evolved in almost half the time a sudden death clinic, where we see families after a young person has died suddenly. The key approach of these clinics is summarised in this slide, and it's a multidisciplinary model of care. As a cardiologist, I always want to think I'm the main man, I'm the one that does everything, But in reality, that's rubbish, because I'm one person in a team of many people, and I'll introduce my team at the end of the talk. But you can see there that the cardiologist is one player. Every patient we see, there's a genetic counsellor sitting with me and advising about various aspects of family and genetic management and counselling. There's geneticists involved, genetic testing and research centres. The cardiothoracic surgeons are often involved in some of the procedures involved in families with these genetic heart conditions. Nurses, GPs, psychologists, patient support groups are so important. I see Anne Kirkmas in the room, who single-handedly has done so much for patients with ICDs, these implantable defibrillators, which we'll talk about. Absolutely essential. Heart Kids, I see Jane Kingston in the audience as well. Wonderful supporters of these sorts of initiatives. And sadly, I see the forensic pathologist probably once every couple of weeks to discuss various results of postmortems and looking at images of sections of the heart, etc. So it is a multidisciplinary approach to care. So how do we look after these families? The first thing we do is we try and get more information about the victim, the person who has died. What were the circumstances of the death? What were they doing? What were they doing the day before? Were they unwell the day before? Did they have a temperature? Had they gone out one evening? Had they had any drugs? All these things have to be asked. Were they exercising at the time? Were they asleep? When were they found? Any information we can get from the ambulance report, the police reports, or us talking to the witnesses can often lead to very important findings. Then we look at the surviving family, and the key point here is that these conditions commonly are genetic, and so the surviving family is at risk of developing the same condition that led to the death of the young person in the family. And as I said, they're mostly autosomal dominant, so you may find many people in the family that have that same condition. So we need to talk to the family, we need to do clinical screening, and I'll touch on some of these things that are in the images here. And we can also use genetic testing with the goal to try and find anyone else in the family that is at a similar risk of dying suddenly. Because if we do, we can initiate appropriate therapies and prevent sudden death. Most recently, we've had a lot more focus on psychosocial wellbeing and support, and understanding that these families, some great internationally recognised work from Dr. Jodie Ingalls and others in our group, that has identified issues of post-traumatic stress, anxiety, depression, which not only lasts for months or even a year or two, lasts for many, many years after the death of a young person. You know, no parent ever expects to bury their son or their daughter. It is the most tragic event of their life. And of course, a parent will never forget what has happened to their child. All we can do is try and help a few aspects, try and work out why the young person died. Number two, try and prevent sudden death in other family members. And three, provide a good support network to help them, to educate them and help them to cope with living day to day. And we tell the families, of course you're never going to get over this death of a son or a daughter, but hopefully every day or every week or every month or every year, you start to cope just a little bit better and get up out of bed a bit easier each morning. So it's a very, very difficult situation. In a proportion of individuals who die suddenly, about 1 in 3 young people who die suddenly in Sydney, no cause is found at postmortem. So there is no thickening of the heart, there's no blocked artery, there's no tearing of the aorta, there's nothing at postmortem. Toxicology is normal, there's no drug overdose, there's no bleed in the brain or anything like that. So that's 1 in 3 people. And so we believe that some of those people who die suddenly, where everything is normal at postmortem, actually have some of these electrical conditions, which I've already mentioned, LQTS syndrome, as one of them. As I said, how common is it? We did a very extensive 10-year study in Sydney, which basically showed that 1/3 of young people who die suddenly every year in Sydney, no cause is found at postmortem. So the family, the parents, are left with a situation where there's no reason why their otherwise healthy son or daughter died suddenly. In looking after these families, I've already told you that we do clinical evaluation of the family, we do basic heart tests to see if anyone in the living family has a condition like long-QT, like hypertrophic cardiomyopathy. But we've also had the opportunity in more recent times to take advantage of the recent genetic technologies. So to give you a perspective on this, about 10 years ago, when we studied genes in patients, it usually took us about 6 months to 1 year to study one gene, right? And the way we did that was we took the gene and we broke it up into pieces and we sequenced one bit, then one bit, then one bit, then one bit. We'd often forget we'd sent the gene test away because it'd be a year later when we're getting the result out. Today, in our laboratory, and we're a very basic laboratory, we can take a blood sample, we can extract the DNA in a day, and we can send a sample off for these techniques called whole exome or whole genome sequencing, where we can sequence all 22,000 genes that we have in 6 weeks. It's an amazing advancement in genetic technology. The problem is our knowledge of all those genes is way behind. We're nowhere near know what those 22,000 genes are. But at least we have the technology to be able to look at those genes. And from our perspective, whether we used to look at 5 heart genes or 10 heart genes, Dr. Richard Bagnall in my group can now look at 150 heart genes in one sitting very quickly. So this technology has been very useful. And so we've used this technology in this setting. And I'm a pretty humble guy, but I'm pretty proud that we've been one of the groups in the world that really led this initiative. And this is called the molecular autopsy. It's very simple, but it took a long while to get everyone on board to understand its significance. So as a result of some of our initiatives, it is now mandated in Australia and New Zealand that any young person who dies suddenly under the age of 40 has to have a 5 ml blood sample collected at post-mortem and kept. That sample may be used for anything, but from our perspective, if it's a cardiac cause, we can use that blood sample to identify whatever gene we're interested in terms of finding out the cause of death. So this is making a diagnosis after death from a blood sample from the post-mortem. When we started this work, and it was only a few years ago, we did a 4-gene test where we looked at the 4 main genes involved in long QT syndrome. But as I've told you already, there's been major advances. So we've gone from 4 to 5 genes to what we call gene chips, where we can look at anything up to 100 genes in one sitting. Or what I mentioned a bit more recently is this exome sequencing, where we can look at 22,000 genes. So on that little sample of blood, we can actually do all this genetic information, get all these genetic tests, obviously targeted specifically for the heart, and see if there's anything there that might explain why that young person died suddenly. Is there a gene related to long QT syndrome, for example? And with that, this is the most busy slide I'm going to show you tonight, but this is just to show you that in leading the world in this way, Dr. Daniel, who is here from my group, published this work earlier this year, which was the first study in the world that applied that exome sequencing technology to a small series of young people who had died suddenly previously. And up to a third of those patients, there were genetic changes identified which either are very likely to be causative of disease or very suspicious. So it's what we call a proof of principle study. This is not coming out in every situation today, but it's very, very exciting to be able to use these technologies to understand more about these conditions. So I've told you a lot of background about sudden death in the young. At the moment, I've told you really focus on individual families. But I guess the question you might be asking is, if we can identify those at risk of sudden death in the living population in this room, can we actually prevent it? And the resounding answer is yes, we can, but we need to know who's at risk. How do we do that? This is a summary of some of the things. Lifestyle modifications. We often tell people not to engage in the highest level of sports because that seems to be a trigger for rhythm problems which can lead to sudden death on the sporting field. We tell them not to do things like bungee jumping, but I think even if you don't have a genetic heart condition, you shouldn't do bungee jumping. It's crazy. That rope's going to break one day. Alarm clocks. I said that before. It sounds crazy, but there are examples of people who have had cardiac arrest when an alarm clock has gone off. And so we tell those people to get alarm clocks which slowly increase in volume as they wake up in the morning so that they get that sudden adrenergic stimulation. I should say I teach the medical students, and some of the medical students came up to me the other day after my talk and they asked what that thing in the corner was because they've never seen an alarm clock before. Medications are useful, which we'll talk about. which we won't talk about much, but useful. Avoiding sudden death triggers. I'm going to give you a few more examples in a moment. And the implantable cardioverter defibrillator, which is a device implanted underneath the chest wall, which prevents or acts on abnormal rhythms in the heart, delivers a shock and stops people dying suddenly. And I'll mention a bit more about that. But this is a summary slide. So I'm going to go on a little slight detour because this is another passion that I have, Arthur. So this is related to sudden death. So as one of the triggers, one of the public health issues which I think are emerging is the impact of energy drinks. Energy drinks are available to a 5-year-old kid. You can walk into a IGA and buy 10 V's or Red Bulls. Who has energy drinks here? Yeah, all the young people say, yeah, good, honest people. About 60% of the population apparently have had energy drinks or have on a regular basis, so it's quite a big proportion. The key points I want to make here is that there is emerging evidence that energy drinks, because of the content, because of the high caffeine, because of this energy blend that they talk about here in the bottom right-hand corner, where it's a bit of a mishmash of, we don't know what's really in there, but there's guarana and taurine and ginseng. This whole combination can lead to increases in heart rate and blood pressure, amongst many other things. If you have a susceptibility to a rhythm problem of the heart, this may trigger it. And so there's been examples in the literature of triggering of rhythm problems and even cardiac arrests. There are many adverse effects of energy drinks which are listed here. The caffeine is the main component. Cardiac effects are big, but there's also neurological effects, sleep disturbances, irritability. There's other effects on late miscarriages, stillbirths. Energy drinks and alcohol. This is a very trendy thing to do. You mix these drinks. I see a few people laughing because they probably had a few. But these have other social problems related to them as well, because if you mix it up with energy drinks with alcohol, you can actually drink more alcohol because you're more awake, and then that leads to more dangerous activities afterwards, such as driving home in a car, having drunk, all these things, violent acts, etc., etc. And there's a culture that's also involved in energy drinks, which may be a factor. The company's trying to get around this, and every time I mention energy drinks in any talk, there's a spy in the audience. And I don't know who it is today, but they're from the Australian Beverages Council. And after I give my talk, somebody emails me or sends me a document in the mail saying how healthy the energy drinks are, and we stick to the regulations. So I don't know who you are, but we'll work it out by the end of the day. But they do other things. So here's an example of this Climax drink, which I wouldn't call it Climax, but that's what they call it. But they've tagged it as a herbal energy drink. But you look at the contents of this drink, it's exactly the same as a Red Bull or a V. But they've added herbal, which might make it sound a bit more healthy. Red Bull shots, where you have a concentrated amount, so you don't have to drink a whole can. You can just drink a shot, and you can have 4 of them at one time if you want to. That's your choice. And there's death reports as well. And they're very clever because this is how they market. So I just went to the homepage of Red Bull. What do you notice about this page? Thrill seeking, excellent. Where's the product? There is no product. You see a can of Red Bull here? That's the way they market these drinks. It's all about the image. It's all about living on the edge. Big surfing waves. There's dudes down here doing this, which I think means they're angry and serious people. It's all about the image. It's living on the edge. It's having wings. But there's no product there because I don't need to show Red Bull. I can because it's all part of the image. Complex marketing strategies, which I don't pretend to know about, but it's very interesting. And you look at the Formula One, and it's the Red Bull Formula One team. It's part of the name of the team. So people don't think twice about the fact that it's an energy drink that could potentially lead to major problems. And Lithuania has been the first European country that's actually banned the sale of energy drinks to young people under the age of 16, which I think is a really one of the public health measures which would be important. Okay, that's my little diversion about energy drinks. If you want to learn more about them, especially the young people who do drink energy drinks, I've written an article on it on our webpage, so you can have a read of that, and you probably still drink energy drinks, but at least you know what you're putting in. So energy drinks are one trigger. Stress is another sudden death trigger. So stressful events can trigger rhythm problems. This is an amazing study. This study was conducted in Germany in the World Cup in 2006.
It was published in the best journal in the world, the New England Journal of Cardiovascular Events During World Cup Soccer. And it's very clever. This is the only graph I'm going to show you today, but bear with me, look, see what it shows. These are cardiovascular events, things like heart attacks, discharges from the defibrillators, etc. In yellow and blue are the 3-month period from May to July of events. And as you can see, yellow and blue is pretty flat. But in 2006, the red is the year of the World Cup Soccer. And it was in Germany, and this data was from Germany. And so it's red, red, red down the bottom, all the same as the previous years, but then you get a peak. Why do you get a peak? Because one is when Germany played Costa Rica. So during that 90 minutes of the match, there was a trebling of cardiac events because the Germans wanted their team to win. And then it went down, and in the second match, Germany versus Poland, it goes up again. Third game, Germany versus Ecuador, they were very confident they were going to win that game. Game 4, Germany versus Sweden, but then the big events, Germany versus Argentina and Germany versus Italy. These are cardiac events within a 90-minute period, which are quadrupling because they're watching a game of soccer and they're into the game. You might be wondering what happened then. They actually didn't make the grand final, the final in the World Cup, and so they didn't really care who won the last game. So we went back to normal. That was Italy versus France. They had the Italians, they had the French, so they didn't really care. But this illustrates to you that stress itself, stress of watching a match, can trigger cardiac events, including sudden death. And I love the conclusion of this paper, which basically said viewing a stressful soccer match more than doubles the risk of an acute cardiovascular event. In view of this excess risk, particularly in men with known coronary heart disease, preventative measures are urgently needed. So to me, that means you turn off the TV and they can't watch it. And who's going to turn off the TV when you're watching a game of rugby or soccer? So you can be rest assured that next time in Australia Timmy Cahill scores a goal, there'll be people having heart attacks everywhere. And so stress can be a sudden death trigger as well. So energy drinks, stress. There are other sudden death triggers. Crazy sports. I know some of the young people in the audience do this a bit. This is a sport of extreme ironing. So these are people that iron in the most ridiculous places. So the adrenaline surges. Look at this guy. He's ironing away. This guy's doing on the back of someone while they're paragliding, hang gliding. So, and here's another guy here. So crazy sports like this are not good in terms of adrenergic stimuli. In terms of prevention of sudden death, we talked about lifestyle modification, medications, avoiding sudden death triggers. But the ICD, the implantable cardiac defibrillator, is the key device that's been the biggest change in the last 10 years in terms of prevention of sudden death. I'll just get it right. So here's the device here, so it's tiny. It's called the ICD, implantable defibrillator. And what you do is you implant this. People like Mr. Nick Heckle, who's in the audience, is one of the esteemed cardiothoracic surgeons at Auckland Southern Hospital for many, many years, who put thousands of these in, I'm sure. Implanted under the chest wall, a wire comes out of the device and sits in the right ventricle of the heart, and it monitors the heart rhythm every beat. If the heart goes into a rhythm that could lead to sudden death, it detects it and then delivers a shock directly to the heart and reverts it back to normal rhythm. So it's exactly like what you see in the movies when they put paddles on the chest, but in this case it's an internal shock of the heart and an automatic shock, so nobody has to actually activate it. And so what we can do, and I'm not going to go into details, but when we see patients, we can look at a risk period and work out of all the patients with, let's say, hypertrophic cardiomyopathy, which part of that whole population, which of those 100 patients with hypertrophic cardiomyopathy are at the highest end of that risk triangle, and those people will end up getting an implantable defibrillator in most cases. And here's an example. This is Anthony Van Loo. He's a Belgian soccer player. He has hypertrophic cardiomyopathy. He's playing here. He's had a cardiac arrest, so he's basically dead, but has a defibrillator in place. Watch his legs. It shocks him. Does it actually work? He just gets up. So 10 years ago, he would not get up because defibrillators weren't used in this setting. So these devices save patients' lives. The challenge for us is working out firstly who needs to have these devices, because everyone can't have one, And secondly, of course, we have to discuss these issues with the patients because these devices are a procedure, they can get infected, they can have inappropriate shocks. He actually wanted to keep playing. If you look at the YouTube clip, they forced him onto the trolley just to get him off the field, but he could have kept playing. It was back to normal within a few seconds. So that's an example of how these devices save lives. There are other ways these devices can save lives. They can save lives by delivering a shock and reverting the rhythm to normal. Here's another way these devices stop people dying suddenly. This guy got shot and his bullet actually landed in the defibrillator. So the defibrillator actually stopped the bullet going into his heart and killing him. So here's an alternative way that these devices could be marketed. If there's any lots of scientific people electronic, you can save lives by the bullets of lodging in the device. And there's newer devices as well, which I won't go into, but these are devices, for example, that don't actually, the lead doesn't actually go in the heart, it sits on top of the heart. So the heart is not open or touched. It's called subcutaneous ICDs. So everything I've said to you so far really has focused on the individual patient, the individual family. But can we do things on a more community public health basis to prevent sudden death? Because everything I've told you so far is individualised. So the next few slides I just want to tell you about, from my perspective, these are some of the areas, these are all works in progress, but I'm keen to share it with you to see what you guys think. So how do we prevent sudden death in the community? Well, the first thing, I'm simple, and I think the simple things will be helpful. The first is educating the community. And if there's two things that are important, is knowing your family history. Everyone in this room should know your family history. I know the genetic counsellors do, and they've probably done 6-generation pedigrees of all their families. But most of us don't know a lot about our family history. Is there a young person in the family, a cousin, who died under the age of 35 from a heart condition? Was there any unexplained SIDS cases or, not even, they don't have to be deceased, young people who have developed heart disease at an early age? If any of those things are present in the family, it's probably wise to see at least a cardiologist or at least a GP and maybe have some basic tests in case it's an inherited heart condition. So family history is really important. So sharing with the community and educating the community to know their family history is really important. It's obviously history for other conditions as well, bowel cancer, breast cancer, all sorts of other neuromuscular conditions. Any history is important in the family. The second thing is exercise-related symptoms, and the main ones we're concerned about is if people get exercise-related symptoms such as blackouts, chest pains, sometimes dizzy spells, etc. These may have no problem, they might not be in any way related to a heart condition, but if you have them, you should at least get some sort of investigation. So that knowledge of family history and exercise-related symptoms is really important. In our sort of small little world here, we've actually set up an Australian Genetic Heart Disease Registry that Dr. Eagles in a PhD established. And this is one of the forums that we allow, that we provide a basis for education of families. So you go to this website, all the information is there about all the different genetic heart conditions, issues related to sudden death. We have a Facebook page, which I'm sure my staff decided to do this so they can use Facebook at work, because now they have an excuse to do it. And we have a Twitter handle as well where we can see, we can sort of share new knowledge and new information about these conditions. So the Australian Genetic Heart Disease Registry is a form of education. So number one is educating the community. Secondly, it's training for CPR skills. Show of hands, at the moment, is it recommended that you only do mouth-to-mouth resuscitation? Anyone believe that? Anyone believe that it's mouth-to-mouth and chest compressions? Anyone believe it's not mouth-to-mouth, just chest compressions? Excellent. So that's right. So there's a few people that didn't quite get it right, but the new information is that we don't do mouth-to-mouth resuscitation anymore. It's all hands, CPR, chest compressions, no mouth-to-mouth, no other aspects of care. So training people for these CPR skills is important. And, there are chains of survival, which you can have 8 links in the chain of survival. But these are the key things: early access, calling 000, early CPR, get down on your knees and start doing the CPR. Early defibrillation, that's what's going to save the patient's life. Every minute that goes past when somebody has a cardiac arrest, your chance of survival reduces by 20% every minute. So you haven't got much time. So why aren't we training everyone to do CPR all the time? Why aren't we training our school kids to have CPR training every year at school for an hour at the beginning of each year at school? Why aren't we training all our sports, our kids who play sports every Saturday, soccer clubs, hockey clubs, rugby clubs, as part of their registration? Why don't they all learn how to do CPR? It'll only take half an hour or an hour. Why can't we mandate that in all schools, in all sports clubs, etc.? It does get done. It does get done in various forms, but it's a very ad hoc and patchy way. Some people do it, some people don't do it. But these are the sorts of simple things. Education about family history, education about symptoms, learning how to do CPR properly, keeping up the training. For those who have seen it, there's been a real big trend in the British Heart Foundation in the US. So everyone knows the song Staying Alive? They're all in your head. Well, the beat of Staying Alive is the perfect compression rate for CPR. So when you're doing CPR next time, just think of John Travolta and Staying Alive. And all the advertisements now, all the sort of YouTube clips show people doing CPR, pump hard, pump fast, to the tune of Staying Alive, and they have Staying Alive in the background. I actually went to one of these training sessions, and I'm going to be a bit embarrassed, but I actually thought to do the CPR, you have to actually dress up. And actually John Travolta. And I went there and dressed up like this, and I realised I didn't have to dress up. And then the third aspect is public access defibrillators. So we all know what that means. So when you go to the airport or when you're at the football stadium, there are defibrillators everywhere on the walls. And I think we've made a lot of advances over the last probably 2 to 3 years in raising awareness of public access defibrillators. Remember what I told you, that when there's a cardiac arrest, the thing that's going to save the life is the defibrillator. CPR is not going to save the life. CPR is going to keep the patient relatively well, circulation maintained until the defibrillator comes and saves the person's life. So the more places we have it, the better. The Melbourne Cricket Ground is considered the safest place to ever have a heart attack in Australia. There's defibrillators everywhere. Peter Frelingos, who was a reporter of the Daily Telegraph, who died in the Fox Studios building, had a heart attack. There were defibrillators everywhere in the building, but no one knew where the defibrillators were. So it's not just having any died. It's not just having defibrillators in the buildings, it's knowing where they are, how to use them, and how to act appropriately when something happens. So public access defibrillators are very important, and we need to promote more. The Japanese are crazy guys. I love the Japanese, but they have defibrillators in vending machines. So whenever they have a vending machine, they actually have a defibrillator at the bottom. So everyone knows where vending machines are. They just go to the bottom, pull out the defibrillator, and use it as required. So you can even have a vending machine. Do these things actually save lives? Well, the answer is of course they do. This is a very famous example from just over 12 months ago. Fabrice Mwamba. Who knows about Fabrice Mwamba? Bolton Wanderers soccer player, was playing a game in front of 70,000 people and had a cardiac arrest. No previous history of any problems. Arrest occurred on the field. That's the face of somebody who's going to go one way or another pretty quickly. Usual situation of people just hysterical. There were about 14 cardiologists that ran onto the field. So that firstly says that cardiologists do have time off and they do go to the football games. But you know what? None of them actually saved his life. It was the defibrillator that saved his life. They, of course, started CPR and managed him. And he's a good story. He went out of hospital, he got a defibrillator, and now he's a big advocate for public access defibrillators and is doing magnificent work in the UK. And I actually read his book recently as well, which is a really good read, which puts into perspective, family and children, and his children were watching the game from a distance on the TV in a different location, and saw it all happen in front of them on the TV. So it's a great book. FIFA are an amazing organisation. So I had the privilege a few weeks ago to be in Zurich to give a talk on one of these genetic cardiomyopathies. And this is the chief medical officer of FIFA. He's actually a neurologist, a brain person, but we won't hold that against him. He's not a cardiologist. But he gave a great talk, and what they've done at FIFA is, after an event that occurred in the early 2000s, 2003 in fact, the person who died was a soccer player called Mark Vivian-Foe, they made resuscitation, CPR training and testing of players a real priority of FIFA. And they've developed these backpacks which have been sent to all the FIFA recognised countries in the world. This backpack has a defibrillator. It has everything you need to keep a person alive for 1 hour. And so they've set the example, they've set the bar really high, because of course they don't want a death on a World Cup, Brazilian World Cup in 2012, whatever it was, an event happening on the world stage. But this is the sort of initiative that's supposed to be in all the local football clubs, or soccer clubs as we know them here in Australia. Who's seen one of these backpacks? Nobody. So there's a disconnect, right? So that's another area that we need to see what's happening and why is there a disconnect there. So my final few slides, I just want to talk about the road ahead. So the clear things I've mentioned so far is in the public health promotion aspect. Education of the community and awareness is extremely important, and it's a key foundation. Teaching people how to do CPR and doing it regularly, it's like teaching kids how to swim. It's as simple, it's that sort of thing. It's part of the growing up of individuals. And thirdly, of course, public access to defibrillators. So what's the road ahead? The message I want to get conveyed to you, and I think is real strength of this campus, is that research is key. Don't ever let anyone bag out research. Medical research is why people live another 15 years longer in the last 50 years. Medical research is why we discovered that these young people are dying suddenly because of not blocked arteries, but because of genetic heart conditions. When Tony Abbott, love him or hate him, says he's going to make a $20 billion research fund, of course he's not going to get a $20 billion research fund. But if he gets a $1 billion research fund, or $1 million, whatever it was, anything will be better than nothing, and there's a real shortage of funding for research. So never let anyone bag out research, because it's the key, and there are better ways to work out who is at risk. The impact of genomics is big. I've already alluded to that today. There are some crazy studies around the world at the moment. There are moral and ethical issues related to some of them. One of them is to genotype or do whole genomes in newborn babies to see how that genomic information will help you look after that baby as they grow up and their risks of various diseases. But genetics is here, and genetics is very powerful, and you only need sort of one person in the community to make a big difference. So people, some of you may have heard of the Angelina effect. So one person, Angelina Jolie, albeit an absolute superstar, because she had a family history, because she was positive for BRCA1, she had a double mastectomy as a preventative measure. In the subsequent 12 months, the number of people in America, women who have gone from breast screening, from BRCA1 gene screening, has doubled. That's one person's act, doubling the rate of getting this awareness of breast cancer, etc. So, these sort of things happen along the way, and I think they're very important to consider as we move forward. So what do we need to do to save more lives? Here is my summary. More education and awareness, more CPR, more what we call PADs or public access defibrillators. And in the last couple of slides, I'll just give you a couple of interesting things that I think need consideration. So this is a school I went to. This is Random Boys High School. This is a very public, very non-selective high school, but a wonderful place, and it's dear to my heart. This is where I'm sending my son at the moment, which is a wonderful school. Trinity Grammar School. Couldn't send him to a better school. Absolutely fantastic. Why am I showing you these two? Is because on Saturday night I was invited to give a talk, just a brief talk, a 5-10 minute talk at a family fundraising event. The family had lost a husband at the age of 38 suddenly, a child that's under the age of 1. So I went to the event and they raised money to, I think, provide 14 defibrillators. The problem is you can't put a defibrillator at Random Boys High School because the government at the moment says you can't put in defibrillators in a public school. Even if you raise the money and pay for it and hand it in, they won't actually put it in the school because of a whole bunch of bureaucratic red tape. Who's going to be responsible? What if it doesn't work? All these excuses which are ridiculous. It's a rare event in children. But what about the parents who drop the kids off every morning and pick them up every afternoon? It's not just the school, it's not just the kids. Whereas in Trinity Grammar, we could donate a defibrillator, and they probably already have defibrillators. In fact, I know they have defibrillators anyway. I'm not picking on any of these schools, I'm highlighting a principle. So simple things like that need to be changed. If a family raises money to put a defibrillator in the school where their son died, let them do it. It might save somebody else's life. So they're the sort of things which I get really passionate about. And we're approaching government in various different ways, and it'll change. We never give up. But these are the sorts of things that I'd like to highlight today. And the public health initiatives, if you haven't already got it already, saving a life. You don't have to dress up like Travolta to learn. Automatic external defibrillators or public access defibrillators, and getting a good patient history and a knowledge of the family history. I had to finish my talk by this principle of mine and to bring into my final couple of slides my passion, my other passion, which I hadn't mentioned to Arthur. I tell all my students, all my staff, never give up. If the rule at the moment is that you can't put a defibrillator in a public school, that's fine, but we're going to change it. Don't give up. Be determined, never say never. So I bring together my second passion to finish. So this, who knows what this is? So this is the march when the Rabbitohs rugby league team got kicked out of the competition in 1999. There was protests in the streets. This is a fact. You don't have to love rugby league for this. You don't even have to know about South Sydney because it's a story about life. They were the foundation club in 1908, the first club, but they were kicked out of the competition by News Limited because they didn't quite reach the threshold of numbers and things. The foundation club kicked out. There was a protest march led by George Pickens and John Sattler at the front there, and the protest march was to Town Hall. The club was kicked out. But they fought and they fought. They said you have to merge with another club to survive. They didn't. They fought, they went to court, they won. They weren't back in the competition in 2002. They came last every year for a few years. Why? Because they had very little money, because they weren't even in the competition for 3 years. And they'd lost all their players. But they never gave up. And very proudly, as most of you know, this year, just a few weeks ago, they won the premiership and won the premiers for 2014. Why do I show this? Because this is my other passion. I love the Rabbitohs. My children and I were there to watch the game. But it's the whole principle of never giving up in what you want to believe in, what you're trying to do, whether it's in cardiovascular medicine, cancer research. Never give up on your desire and your passion. So, my last slide is my summary slide. Sudden death in the young, including athletes, is a complication of a number of genetic heart conditions. Many advances have been made in the diagnosis and the management of these conditions, and I hope I've given you a flavour of many of those. I think this is really important. A combination of high-quality medical research and effective public health measures, such as education, such as CPR training, etc., is critical. And I think we're all here today, we're all united from different disciplines, because we're united in that goal, the ultimate goal to prevent sudden death amongst young people in our communities, in fact, all people of all ages. And finally, today I'm just presenting, I'm really a mouthpiece. I have a team of people who are absolutely awesome, some of whom are in the audience. It's my privilege every day to come to work and lead this team of people. There's some really young people in our group, like Karina, who's 20 or something, ridiculously young. And then there's some older people who I won't mention as well. But these guys, they're not overpaid. They don't work, 9 to 4. They work their butts off, they get paid very little. It can be very demanding, but they're all passionate about doing something, and their passion is to help families with genetic heart diseases. And I'm so proud to be leading that group. Number of supporters, Heart Kids, Heart Foundation, NHMRC. So on that note, I'd like to say thank you for your attention. I'm happy to answer a few questions if you have any questions, and I hope you've learned something today.